Hi everyone, my name is Amanda Liu and joining me is Julia Conway. We are both technical managers in IHPA's pricing team. Today we'll be discussing the pricing of community mental health care using the Australian Mental Health Care Classification version 1 or AMHCC version 1 for short. We'll discuss the different cost model options explored for pricing community mental health care in 2022 and also consider the policy implications of these alternative pricing models. In 2016, IHPA finalised the development of AMHCC version 1, which sought to better classify, cost and price specialist mental health care compared to the existing AR-DRG classification and block funding arrangements. The AMHCC uses a clinician-rated data element called the mental health phase of care, which describes the prospective primary goal of care for the consumer. The 5 phases of care that act as the splitting variables in AMHCC version 1 are acute, functional gain, intensive extended, consolidating gain, and assessment only. For example, the acute phase is selected where the primary goal is to reduce high levels of distress, manage complex symptoms, and reduce immediate risk. Other key variables for the classification include the service setting, so admitted versus community, the consumer's age, the mental health legal status, as well as their HoNOS and LSP16 scores, both of which measure the health and social functioning of people with mental illnesses. Using phase-level cost data collected under AMHCC version 1, IHPA has developed mental health care cost models for both the admitted and community settings. The community mental health care cost model was shadow priced for the first time as part of the National Efficient Price 2021-22 determination, that is NEP 21, and it will continue to be shadow priced for a second year in 2022. AMHCC version 1 activity and cost data has been collected for several years now, and we have seen year-on-year improvements in the data quantity, quality, and reporting coverage. On the back of improvements in the data, we revisited the cost model structure for community mental health care. Each graph you see here represents an example of what the model cost would look like for a single AMHCC end class. The shadow community AMHCC cost model used for NEP 21 had a hybrid cost model structure. This was a combination of fixed and time-based models, depending on the mental health phase of care. Assessment-only phases, which are time-limited, used a fixed cost model. Acute phases use a fixed cost plus per diem rate based on the length of stay, and all other phases, that is your functional gain, intensive extended, and consolidating gain, used a per month rate, recognizing the typically longer length of stays for these phases. For 2022, there were 2 alternative model structures considered for pricing community mental health. The first was a per diem cost model, where the model cost is a fixed cost plus a per diem rate based on the length of stay. This is for all phases of care. And the second option was a service contact model based on the number of service contacts per phase. So for each end class, the model cost would consist of a fixed cost plus a weight per service contact, differentiated by whether the consumer participated in the service contact or not. Generally speaking, service contacts with a consumer present would attract a higher cost or weighting than service contacts where the consumer is not present. Another thing to point out is that both options include a fixed cost component, as seen in the graphs where the intercept is above 0. In evaluating these alternative model structures, we looked at 2 key measures, the first of which was a R-squared to evaluate the model statistical fit, where a higher R-squared implies that the model captures more of the cost variation. And the second was at cost ratios to evaluate how well the model predicts actual costs. The table results you see here are based on the 2019-20 mental health activity and cost data, underpinning the National Efficient Price 2022-23 determination, that is NEP 22, that was released in March of this year. As you can see, the per diem model has an R-squared that is comparable to the hybrid model and performs well in accounting for variation in phase length. The service contact model performs considerably better than both the hybrid and per diem models, and this result aligns with the empirical analysis showing that the number of service contacts is the single most powerful variable in explaining variation in phase cost. If you look at the cost ratios, that is the ratio of actual costs over model costs, for jurisdictions which provided costed phase level activity, we can see that all 3 models are generally pretty good at predicting actual costs, with most cost ratios falling between 0.8 and 1.2. The service contact model performs marginally better than all the other model options, with the biggest improvements noted in Tasmania. In addition to community cost model performance, IHPA has also considered the risks and incentives associated with possible implementation of different cost model structures. As previously outlined, the existing hybrid model prices the majority of phase types using a monthly rate, which does not adequately account for the variation in phase length and may incentivize extending consumer care and phase length beyond set monthly boundaries. This can be partially addressed with a per diem model. However, the limitation of using either time-based pricing models is that long phases with minimal service contacts will continue to receive the same price as phases of similar length with many service contacts, and this is illustrated in the example here. Therefore, a time-based model may not adequately account for the variation in cost associated with consumer-related activities, and there is a risk that this could lead to or even incentivize underservicing in community mental health care. This outcome would be inconsistent with IHPA's pricing guidelines, which state that pricing models should seek to minimize susceptibility to inappropriate rewards and perverse incentives wherever possible. The Productivity Commission report into mental health identified that in 2017-18, only 29% of clinical staff time at community mental health care services was spent on consumer-related activities, and of that, only 20% was spent directly with consumers present, falling short of national benchmarks. It posited that this may, in part, be due to the amount of funding being independent of the amount of care provided. The adoption of a service contact model may help address this issue by attaching funding to service contacts, thereby potentially improving quality of care by better aligning funding to costs and incentivizing more direct consumer care activities. This pricing structure may also better support consumer involvement in their care through better alignment to the higher costs of service contacts with consumers present, and the fact that these contacts generally attract a higher price than contacts without the consumer present. While there is potentially a risk of incentivizing overservicing, both the Productivity Commission and Victorian Royal Commission into Mental Health Services found that there has been a history of inadequate supply of public specialist mental health care services in the community, with service hours falling short of estimated demand. They found that many people who need community mental health care services are not getting access to them, and where consumers did access them, this was often not at the intensity or duration required. Overservicing is a common concern about activity-based funding arrangements. However, given the particular concerns and evidence of underservicing in the community mental health care setting, the risk of overservicing being driven by a service contact pricing structure is probably lower than in other care streams. However, IHPA will continue to monitor this risk over time as the community AMHCC cost model continues to be developed. During 2021 and 22, IHPA consulted with its jurisdictional committees, mental health working group, and health ministers to obtain feedback on the proposed adoption of the service contact cost model. Based on the substantially better performance of the service contact cost model in accurately predicting phase costs, and with consideration of the fact that it may reduce the risk of underservicing incentives, it has been adopted for use in shadow pricing the community side of AMHCC version 1, and this was outlined in the National Efficient Price 22-23 determination that was released in March 2022. IHPA will continue to develop the community AMHCC cost model with new data and stakeholder feedback as it comes available. Thanks for listening today.